Hi and good afternoon, everyone. I am so glad that you've joined us for this wonderful webinar. We'll be having the last one of 2021. We'll be talking about PF care teams and ILD care teams today, a little about who they are, what they are, and the important roles that the different members play. And I am just so happy to welcome my colleague, Dr. Krishna Davaraja. She is the director of the ILD program at Henry Ford Hospital, the director of the Care Center Network site there. She's a clinical assistant professor at Wayne State University School of Medicine. So I just want to dive right into this topic. Krishna, thank you so much for being here. So without any further ado, Dr. Davaraja, welcome again and thank you for being here.
Great. Thank you, Dr. Case. So thank you to everyone who's attending. So what we're going to be talking today about is, as Dr. Case mentioned, what care providers should you know, or what is a care team is, I think, for me, the simpler way to look at this. If I can get my next slide to show. Let's see if I can do it. Okay, there we go. There we go. Sorry for the delay there. So that's me without a mask. Right now I'm sitting in my office alone, so I get to be unmasked, but few people get to see me this way anymore. So medical disclaimer. So any of the information contained in this presentation is for informational and or educational purposes only. It is not intended to be a substitute for professional medical advice. Always consult your personal physician or healthcare provider with any questions you may have regarding your specific medical condition. I don't have any financial disclosures relevant to this talk. And so I like to try to keep things simple. So here is the overview. So we're going to talk about the various members of a care team and potential roles that those people play, and then a few examples of care teams in action. So just a brief review of terminology. I think that the terminology we use is still really confusing, so I thought I'd just touch on this because sometimes people will say, well, I have pulmonary fibrosis, I don't have interstitial lung disease. So just to review, interstitial lung disease is a grouping of over 150 different disorders which cause inflammation and or scarring in the lungs. Pulmonary fibrosis is a type of interstitial lung disease, and it's lung disease with scarring. Scarring is not reversible, and specifically another diagnosis is idiopathic pulmonary fibrosis, which is a type of lung scarring that progresses over time and has a specific radiographic and pathologic pattern, and by definition has no cause. So when you talk about these disorders, someone might say someone with IPF has a type of pulmonary fibrosis, which is a type of interstitial lung disease. Someone with rheumatoid arthritis, we would not call them IPF because they have a cause for their disease. And then looking at somebody who has maybe a self-limited course, someone who had a drug reaction that gets better, we wouldn't label them as pulmonary fibrosis. So just to get some of the terminology that we use a lot out of the way. What is a care team? So a care team, the broad definition, is a group of professionals who contribute to the treatment and care of a patient. Very broad. And this actually can look very different across different care settings. So in a private practice office, even within that, there's a lot of variability. A larger group practice in a large city versus a practice in a rural setting may have different folks working in that practice and playing different roles. And then if you look at an academic institution, in a lot of them they'll have a general pulmonary practice clinic, and then they'll have subspecialty clinics, and the one we're talking about would be an interstitial lung disease clinic or center. So multidisciplinary care in ILD, what this initially referred to was were the studies that showed benefit of using a multidisciplinary discussion, pulmonologists, radiologists, pathologists if someone had had a biopsy, to form a consensus diagnosis. Now there are actually studies starting to look at how a multidisciplinary team in the clinic can improve the care of our patients with ILD. And this is my team. in multidisciplinary conference, and then this is our much less formal one, and I figured this was okay to use because I was the least dressed up. I think I was rounding in the ICU at that time. But physicians or administrative assistant, pharmacist, social worker, nurse coordinator, and nurse practitioner in our group. So team members that you may encounter: physician, an advanced practice provider, which would be a nurse practitioner or a physician's assistant, nurse specialist, social worker, respiratory therapist, the pulmonary rehab team, and then pharmacy in some practices. So looking at what I think I'll think about is the pulmonologist, so the physician of the group. So the pathway that this person follows is they'll go through medical school, residency, and pulmonary with the option of also doing critical care, and most train in pulmonary and critical care medicine. And then there are very few specific training years for interstitial lung disease, but for the most part, folks who train at a center for interstitial lung disease will be the folks that go on to continue caring for patients with interstitial lung disease and have a focus in that area. Responsibilities, so diagnosis, and this sometimes takes more than one visit. So this is that extensive history and physical exam, and even that can look different in different practices. Some will use questionnaires before the patient's seen. Others will do all of that face-to-face in the room. And the physician will discuss with you the patient, their impression, and in many cases additional diagnostics, which might include anything from blood work, consultations, breathing tests, walking tests, imaging, and potentially sampling, depending on everything that's seen. There may also be some discussion regarding other contributors to shortness of breath and cough and fatigue, so really trying to address those symptoms as well. And the other things that that pulmonologist is doing is coming up with a treatment plan. So this might involve discussing with, if you've been referred to another pulmonologist, discussing with your primary pulmonologist or your primary care physician that are already part of your care team. And so discussing potential risk benefits of therapies that may be available. Some cases may also involve lung transplant discussion. And then, like I said, evaluating those contributors to shortness of breath and cough and fatigue, and oftentimes discussing future plans. And this may not always be at the first visit, but assessing needs for additional layers of support. And you'll see that's a common theme for just about every member of the team. The advanced practice provider, so the pathway here is it's for the nurse practitioner or physician assistant. There are specific schools for this. So they undergo training with up-training in clinic and then or a hospital setting to practice usually in a more focused area. So to give you an example, the nurse practitioner in the program that I work in was an ICU nurse for over 10 years. She went back to school to train as a nurse practitioner and then worked in primary care clinics for about 2 years before joining our team and up training with our interstitial lung disease team. So potential responsibilities, and this is all under the supervision of a physician. In some practices, they are involved with new intakes. In others, return or follow-up visits only, drug management, sometimes sick visits, return visits, phone calls if somebody's not feeling well, disease and medication education. In some cases, they're also working on the prior authorizations, and again, that discussing future plans and assessing needs for additional layers of support. When we think about our pulmonary nurses, so in a lot of practices, that pulmonary nurse is working with a lot of different disorders, lung diseases. So often, so how the pulmonary nurse gets to that place is they've completed a nursing degree, they do specific up-training in pulmonary medicine in the outpatient setting. Sometimes there's some inpatient background as well. And the potential roles working with the physician and or an advanced practice provider, triaging sick calls, coordinating urgent appointments, also helping with disease and medication education, oxygen, nebulizer equipment education, and just simply figuring out how to get the patient that equipment. Refill management, prior authorization help, and then aid in referrals. when you look at a subspecialty clinic, a specific ILD clinic, that's often called a nurse specialist or a nurse coordinator in some programs, and same pathway in terms of training initially, but there's additional uptraining in very specific to ILD, and so the roles that the pulmonary nurse typically plays is the same, but again having a bit more concentration on interstitial lung disease. And again, the nurse specialists and the pulmonary nurses are also really great about looking at, geez, where else can we help our patients improve their quality of life? So we're looking at ways to make life easier or and improve symptoms. Social worker. So my favorite question when we had a social worker join our team was that someone just looked at me and said, why on earth would I ever need a social worker? I don't understand what's going on here. And so what does a social worker do? And I feel like I am still learning every day about the amazing things that a social worker can add to someone's care. So this is someone who trains in social work medicine, either as a licensed clinical social worker or has a master's of social work. So potential roles. So they may assess social support for visits, it may help walk through complex medication regimens, something as I think fundamental as, geez, how are you going to actually remember to take all of your medications? Your list is getting longer. How do we coordinate that? What are your strategies to work on that? The social workers can work on helping set goals, following treatment plans, including keeping up with medications, visits, pulmonary rehab, can aid in access to care. And so they'll look into medical and community resources. Oftentimes this can also involve transportation. If there are questions about disability, they have a wealth of knowledge on these areas. And again, this is another member who is advocating for the patient, looking at how can we make life better for that person. Respiratory therapist. And just to, I should have mentioned earlier, not every team has this. And so that doesn't mean that one team is better than another team or worse than another team. It really just means these are the resources that this team has, and this is how they've used those members to fill all of the needs of a patient. So some of the roles that I'm listing for respiratory therapists are done by pulmonary nurses in other practices. So a respiratory therapist is someone who's trained specifically in aiding in identification and treatment of breathing issues. I think we're most familiar with respiratory therapists in the hospital setting, but they do work with us in pulmonary rehab and in some clinics as well. And at times are the ones performing the breathing test. Sometimes that's a respiratory technician who doesn't have as much training, but again, there's a spectrum of training there. Potential roles, respiratory therapist works with other team members to create a treatment plan, can help with education on breathing techniques, inhaled medications, how to use them, and oxygen therapy. And then administration of aerosolized medications. And then at pulmonary rehab are helping with assessing oxygenation, someone's progress, and education again on breathing techniques. And then the pharmacist. So pharmacy. So these are folks who specialize in the preparation, properties, effects, and use of medications, and this is several years of training. And so potential roles, I think the pharmacist sometimes is behind the scenes, so I think we all have great knowledge of the ones that are at our local pharmacies, but for patients who are on some of the more specialized medications like an antifibrotic or an immunosuppressing agent, a lot of times there's a specialty pharmacist behind the scenes helping kind of look through medication regimens. So what the pharmacist can help with: medication education, how to take medications, food, without food, are there things that seem to make it less tolerable for people that could, changing something would help, and then potential side effects. They screen for drug interactions. They provide alternate suggestions to be reviewed by providers. So again, just to give you an example, there's many different ways for this to run, but in the group that I work in, we have a pharmacist that works with our team, and so when I'm starting a new medication and I notice a little bit longer list, and I think that, they're not ones that maybe I'm as familiar with because they're non-pulmonary medications, I want to make sure that I'm not going to cause more issues with these medications, so I'll walk through that with the pharmacist, and we'll come up with, geez, is there going to be one medication versus another that's better based on that person's medication profile. And then a specialty pharmacist has just even more focused knowledge on classes of medication used for interstitial lung disease, and can, in some models, can help with the lab monitoring and refills if there's a collaborative practice. And then administration, oh my goodness, the people who get everything done. So these are really the folks who keep things running. So a lot of potential roles here for administration. They're also referred to as office staff, the front desk, so scheduling, visits, testing, directions on how to get medical records, even just how to get to the hospital or the clinic for different testing, directing those phone calls when something isn't quite going right or you just need to reschedule, sending out letters of the visits to referring physicians, so helping with that communication back to your main doctor, faxing paperwork, aiding and billing insurance, also help with prior authorization filing, and then supplies, so things like education handouts, the things that I feel like we need on an everyday basis, and we would collapse without them. So I'm always very grateful. So that was kind of I think a very broad overview of some of the different folks that are members. So I thought I'd give try to give some specific examples and walk through, in this practice, this is what's done. And this is what's maybe happening sometimes behind the scenes, or maybe helps you understand, hopefully, why this other person's involved. Because I'll also get asked, well, why can't I just talk to you all the time? And sometimes I need help in terms of areas of expertise. For me, the social worker is always a great example of someone who has dramatically improved the lives of my patients. So I look to these folks in the team as help. So an initial visit. So I'll just walk you through this, and I just tried to, these are not people, these are from the PowerPoint stock images, but so these are not real people, but the initial, not actual patients, but the initial visit. So Alice calls the pulmonary office. She wants to set up a new visit. She's been referred by her primary care physician. The office staff instruct Alice to bring any records that she has and schedules the visit. And that already makes the visit that much better for when Alice goes in, because having those records really can round out sort of the story. Alice checks in with the front desk staff, is roomed by the medical assistant, put into a room. They walk through why she's coming in, her medications, her allergies, and take vital signs. So the pulmonologist, Dr. T, goes in to evaluate the patient based on the history and physical exam. She orders breathing tests, walking tests, and a high-resolution CAT scan. So the nurse that works in the clinic, Nurse Kyra, walks Alice through the process of scheduling, reviews them, any medications that have been prescribed that day to help with the cough that she's experiencing. And so Alice then goes, to check out and is scheduled for testing. Some of that is fit in by that day. And in this practice, there's a respiratory therapist who helps perform the testing. Based on the testing, and this happens. We expect sort of a straightforward, we have an expectation of what's going to happen during a visit, and we sometimes get surprised. So on that walk test, Alice actually needs oxygen with walking. And so Kyra then, we take a step back. Kyra walks through, all of this information that we need to send in that oxygen prescription, and then walks Alice through, what does this mean? How do you use this? Who's going to call you to set this up, and what to do if things are not seeming to work, or if there's anything that you forget that the clinic can help with. So just still walking through that same case. So just kind of walking through that new diagnosis and some troubleshooting at the same time. So as Alice and Kyra had talked about, she hasn't been called by the oxygen company, and she's a little concerned. She needs oxygen with walking around, and so she's worried about walking without the oxygen, and of course calls the clinic as she's been instructed to do. So Nurse Kyra gets the call sent to her from the front desk, and calls Alice back and verifies, we sent the fax. She's looking through the paperwork, making sure that the fax has been sent, and then calls to figure out what exactly happened, and so sorts out whatever the issue is here. And so Alice, and then goes back to Alice and kind of discusses the delay and what's going to happen next. So based on this communication, oxygen is delivered later that day. And then Kyra, just because it's overwhelming, walks Alice through again, geez, how to use the oxygen and what to do when it gets there, and then to call again if there's really any other issues that come up. In the meantime, Dr. T has gone through the rest of the testing that's been done, and then presented at Alice's case in the multidisciplinary conference that we mentioned before to come up with a consensus diagnosis and that initial treatment plan. So she meets with Alice to review the diagnosis and then discusses a treatment plan to make sure that this is something that works for Alice, and then discusses some additional options of pulmonary rehab, support group information, medications that she's thinking about prescribing, and then, geez, what are we doing for follow-up? And so Nurse Kyra kind of circles back again to review the instructions from this office visit, and the office staff is sending in the referrals, and then this new medication prescription triggers a call from, in this case, from the pharmacy team to review. So this is one where a pharmacist is part of the team. And so the pharmacist calls Alice to walk through that medication, what the process of approval is, what the monitoring will be, and helps coordinate that. Okay. So that was one case. So the next case is one where a patient is going to pulmonary rehab. So John arrives to his pulmonary rehab intake visit, and he's evaluated by a pulmonary nurse. So the intake can be done actually by different members of the team, but in some practices it's done by the pulmonary nurse, some it's done by a respiratory therapist, and others it may be even done by a physical therapist. All of this is within realm of expected and usual practice. So John performs a 6-minute walk test, so it's measured the distance he can walk in 6 minutes, and with checking of the heart rate, blood pressure, oxygenation, and then symptom scores for shortness of breath and fatigue. And so his first session consists of, when he goes back, because there's the intake visit, when he goes back, consists of training on the equipment and a discussion of breathing techniques by the respiratory therapist. So this team has a pulmonary rehab nurse, a respiratory therapist, and there may also be a physical therapist involved. Okay. The next scenario is someone starting on medication, and this is in a different practice than the one that I discussed first. And so, so this is a gentleman starting on medication to treat his interstitial lung disease. As that medication requires a specialty pharmacy and monitoring blood work and office visit, the physician lets him know that the nurse in this practice, Nurse Lois, will be in to review the next steps. So Nurse Lois goes in to review the medication application process, recommended monitoring, and visits with John. And then that script is sent to a specialty pharmacy. So the office staff works on a prior authorization, and the specialty pharmacy that's supplying the medication actually has a nurse educator that works for them. And so that person, that nurse educator, is calling, this is John, calling John to review the next steps in starting the medication, and then also is an additional layer of support for future issues. And so this is just a slightly different model than the first one that I had presented, where it was a pharmacist working directly in the clinic with the team. You may not see that person. It may be someone that works either for a specialty pharmacy or for the pharmaceutical company, and is again an added layer, can be an added layer of support to troubleshoot medication issues or access issues with medications. Okay, and so this next scenario is when someone is feeling worse. So Mary is a patient who has interstitial lung disease and has noticed an increase in breathlessness and cough over the past 2 days. And so as she was instructed during her first visit, the team wants to know if she's feeling any worse. So she calls the clinic and speaks to Nurse Sean. And so he asks her some screening questions and tries to troubleshoot common issues. So he asks about, geez, are you checking your oxygen levels? Are they any lower, to make sure that she doesn't need to go to the emergency department, and is also asking screening questions that when you're getting asked these by the nurse, this is created by the team together to say, oh, okay, if this is happening, geez, we know that we need to send somebody into the hospital. And so what'll happen is that sometimes you'll get asked those questions to make sure that it's not a medical emergency and that we don't need to divert, or geez, are there some certain things that come up that can just be addressed right there over the phone? And so that's where a lot of that conversation with the nurses and sometimes the advanced practice providers comes from. And sometimes we can troubleshoot things without having to bring people into the clinic, or of course we want to avoid bringing people in the hospital if we can. So Nurse Sean reviews with NP Michael, who in review with the physician offers to see Mary in clinic that day. So Nurse Sean calls Mary to review this information. So the NP sees Mary in clinic and reviews his concern that Mary has a bronchitis and that maybe she needs antibiotics and steroids. So this is all done by NP Michael and reviews that with the physician. So not at every visit does the patient see the physician, but that communication, I think, even if you're not seeing it happen, is constantly happening between the advanced practice providers and the physicians. And I think that's another area that people just don't realize, and I don't know that there would be a reason why we would know that this is happening, but I thought I would highlight a scenario where our NP is able to handle a situation. Okay. And then routine follow-up. And so this is a lengthy one, because I think routine follow-up there's nothing really routine about it. We are looking for why your physicians ask you and your APPs ask you to come back to clinic at certain time frames is because there's so much that we want to address with you and make sure that we're doing the best that we can in terms of addressing your medical issues and symptoms. So John returns to clinic for his 3-month follow-up with breathing and walking tests. So the APP, Beth, reviews his symptoms, asks about how he's tolerating medications, examines him, and reviews a plan of care. When she's reviewing the breathing test, which she reviews with the physician for every single patient she's seeing, something seems off to her about the breathing test that day, and so she steps out to find Dr. A to see the patient that day with her. So thankfully, when they review everything together, it looks like John's allergies maybe were acting up, and so he was coughing during the breathing test, and the tests were just seemed to be some falsely low readings. They reviewed the most recent CAT scan again, and as his symptoms besides the allergies seemed to be stable, there was less concern. So this is good news. So John, as we encourage actually all of our patients to come with a family member or friend to have another set of ears and another advocate. So John's wife is at the visit with him that day and mentions that John is overwhelmed. He would not tell us this, but she sees things and she's concerned. And so she feels like he's overwhelmed with the diagnosis, and he's still adjusting to he needs oxygen with exercise, and he's still adjusting to that. And so Beth and Dr. A discuss John's case with the social worker Tariq in the clinic, and who calls him after the visit to review what's out there. Support groups which have been brought up to John in the past, but he wasn't quite ready to hear about it during that first visit, which is completely understandable. They do talk about if he's interested in behavioral medicine referral in terms of looking at coping strategies, they also talk about community programs that are out there to support him. And a major concern for John is, geez, what does he do when he's not able to work anymore? And that's really what's weighing heavily on him. And so Tarek gives him information, what that sort of looks like, what those applications involve, and provides information on that end as well. And this would be challenging to perform all in one visit, and so oftentimes there are phone calls after the visits to close the loop on some of these, to address all of these issues. Okay. And so as always, I probably talked a little too fast, but I wanted to just again thank everyone for your time and address that the care team is a group of healthcare providers formed with that goal of providing coordinated, comprehensive care for the individual patient and family. And I'm happy to take any questions. And again, thank you for your time and attention.
Thank you so much. That was wonderful. It gave me a lot to think about, and I took a few notes, and I know we have a lot of questions. So just about the care team and our interactions with them and members of them. So if you're up, I think we have some opportunities to discuss here. All right. So one question we got, I think you touched on this, but we hear a lot about the multidisciplinary conference and that multidisciplinary team. That's a team. Then there's like our care team that we've been talking a lot about in detail. So one of the questions we have is about the role of a radiologist on that care team, and then I would have a second question: are there people on the multidisciplinary conferencing group, radiology, pathology, obviously the clinician, that might play an ongoing role on the care team, and how much overlap is there?
Okay. Oh, both really good questions. So I'll just start with we'll go with the multidisciplinary discussion team. So that is really focused on establishing a diagnosis. We also use that team to kind of get a sense of where things are at with someone. So if we have a new CAT scan and there's some question, is something getting better or worse, we might look at it together again. We've gone back and re-reviewed pathology slides for someone who maybe had a biopsy done somewhere else. So what the radiologist's role is, again, is in that initial diagnosis, and we will try to have as many films that are helpful to us, chest imaging, that we can review over time to get a sense of, is this something that's getting worse over time, or has it been stable? And the radiologist is helpful in that sense, and also in helping form a differential around what that radiograph represents, and may help us hone down on what we're thinking might be wrong with the patient, what the actual diagnosis may be. Ongoing, the radiologist's role is when one of us picks up the phones and calls them in clinic and says, hey, we're going to see this gentleman later today. Can we walk through the film together? To me, it looks the same, but I want to verify. So a really great resource in that sense. The other place they play a role is in, again, the formal multidisciplinary team meetings to, again, revisit if maybe something's changed where we're questioning a diagnosis, or saying, do we have to maybe change treatment plans? So knowing if that imaging is changing is really key. So do we see the radiologist, the pathologist in clinic? No. And so the way that, teams have different ways of running, and so some of the care teams will have, I'll give you an example. When we added the pharmacist and social worker to our team around the same time last year, what we started doing was a weekly meeting to talk about, when we're starting somebody on a medication, if there's an issue that's come up with the medication, and we're all in the room together in terms of the folks who are based in the clinic. And sometimes we'll do that formally. We do that informally, and I think most practices do this throughout the day and throughout the week, that we're constantly in communication about issues that may come up to one member of the team that we feel like another member could help with. Does that answer the question, Dr. Case?
Yeah, I think that was a great answer. Since you brought up communication, we have a question from one of our listeners about communication between not just members of the immediate care team, but all of their healthcare professionals that they work with. Maybe this is outside this core team that you talked about, but maybe a primary care provider or a cardiologist or someone else that they're seeing. How is it that we communicate and coordinate care together? Should we have the expectation that our pulmonologist is making a phone call to the primary care doctor and the cardiologist and so on after every visit? I think helping people understand how to communicate with one another is helpful.
So I think in terms of what I think the basic expectation of communication, if and now it's much easier with the electronic health records. Before that, I'm not really sure how this worked as well as it does. There's a really large network of provider information, even from different states, within these electronic health records. So when I see a patient and say for the first time and say she asks, hey, can you send that note to my cardiologist, that's usually never a problem. Let's say where I pick up the phone a bit more often, if it's another pulmonologist referring to me, and let's say the person's coming from 3 hours away, they love their pulmonologist who's done a phenomenal job with them, and they're going to keep seeing them, and maybe I see them once a year to make sure there's nothing else I can add. That one is a phone call typically for me. I know other practices work differently. They might send a letter, but at the very least is the letter, and we have a way that we speak to each other in these letters and notes that people can glean what we're trying to do. If there's a major change that I'm making, or let's say, geez, I'm worried about a medication side effect and for someone's heart condition. Maybe I call that provider to make sure that I am, again, not going to make something worse. That this happens a lot with maybe the oncologist. Would this be okay? And would my adding this type of medication interfere with what you're trying to do for maybe some, another condition? I think those phone calls are really helpful. But I think the letters, like I said, I have gotten a lot better in terms of being able to find folks to communicate. And I know that the primary cares absolutely want to be updated. They want to know what's going on just as much as our patients do and as much as we do. So we try to keep that line very open. And I've been lucky where we've had primary care physicians call us to follow up after a visit if they didn't understand something. And so we try to keep it that the door is very open.
Absolutely. Yeah, I think that it's important to know that there are multiple ways of communicating. I think as healthcare professionals, our primary way of communicating with others is by our written records, right? If you didn't write it down, it didn't happen. And so it's always important to write things down so that it is reviewable. So many things hit you during the day that you don't want to just rely on your own memory. Or the notes in your pocket. And so having that written and attached to a patient's chart is very helpful, puts it in context. You can easily access other pieces of the medical record. It's always that's easiest in the same system if people are under the same healthcare system or they're using the same medical record. And if people feel like that those messages are not getting across in that way, they maybe need to ask, primary care doctor, are you seeing these records from my pulmonologist? Are you seeing the records from my cardiologist? If so, if not, what is the disconnect? Is there a fax machine problem? Do we need to specifically be waiting for these things to come through? Do we need to change? Maybe we have the wrong contact information. And I think your point about when you might more often call versus send a written message. And there are also these inside the medical record system, there are messaging services almost in like an instant or email type message that connects to the chart that helps facilitate communication during those working contacts. But when might I pick up the phone? Maybe it's when I'm co-managing something with a rheumatologist and I think something needs to change, or I think something is acutely wrong. And I might call one of my colleagues in the hospital and say, hey, guess what? I'm going to have to send this patient over. I want to tell you directly right now. I can't wait for you to go into your medical record system and look for those messages or be checking them later. And so there are different ways of making those communications, perhaps with different different levels of urgency and inside and outside systems and things like that. I have gotten a couple of questions about other types of physicians that might be on a care team, and you talked a lot about kind of the core team, the members of the PFF's care center networks with 68 sites around the country. There are a certain number of required positions on the care team that are there, a physician director, an associate director, nurse, research coordinator, people like that. And then to have access to, maybe not on the primary core team, but a cardiologist or rheumatologist. Can those types of doctors, other doctors, be on the care team? And how does that work?
Yeah, thank you. No, so absolutely. I think I think we maybe limit ourselves too much by thinking of it just in the clinic. I tried to concentrate on what we see in within the pulmonary clinic, but the primary care physician is part of the care team. If someone goes to see palliative care, that provider is part of the care team. The cardiologist also part of that care team. And so I think we probably should think of it a bit more broadly. And I think it goes back to what you were mentioning about communication as well. I think that that team works better if folks are aware of what the others are doing in general. And again, if some major change needs to be made, communicating whether that's by internal messaging system, letter, or phone call.
Absolutely. We are definitely a connected society at this point. There are multiple ways to get in touch with folks. So here's a good question. We have so many great questions. You guys keep them coming. These are really good. If I have a question, I'm a patient and I have a question, but I'm not really sure who I should on the care team. Like, who do I call? I don't really know. Well, who do I send that question to if I'm not sure where that question should go? Who would be the best person to get in touch with?
That's a great question. We often struggle with that as well. Like, how do we get that person to the person who can best address it directly? And that's a challenge, getting you to that person directly. So oftentimes there is someone that kind of runs, we call it triage, we call it maybe answering that first phone call, and sometimes that's the front staff, and we'll say, oh, okay, you have a question about a medication. Okay, let me get you to this person. Oh, I see. You have a question about your test results. Okay, let me get you the nurse practitioner you saw last time. And so I think there's someone that kind of leads that communication hub of, okay, hey, that's a great question. Let me get to this. So sometimes it is just calling the office directly. Some clinics will offer a devoted nursing line, and it just depends on the practice. But a lot of times it is the office. The first line is that office number.
I feel like among care teams, there may be different people with different degrees or backgrounds that do a lot of it. You mentioned so many things that overlap between the roles and responsibilities of these different people, and you gave so many great scenarios about how each one of those different roles contributed to the care of maybe one particular problem, is identifying it and then kind of triaging and then figuring out a care plan and then, educating on the care plan and so on. So I think there's so much overlap. Oftentimes, if you're in one of our care centers, I think our nurse specialists are generally a really good place to start because they have sort of almost a leadership role in that group, and oftentimes know, you can ask your question, and even if it's not that nurse specialist, primary responsibility, they can say, oh, yes, I know, you need to talk to X, here, I'll connect you to them. And so I think oftentimes we lean on that either somebody who has like a triage responsibility or our nurse specialists in the individual organizations to kind of know who does this job in that, because there is so much overlap. So it's never wrong to ask who answers the phone, and they can oftentimes kind of help you figure that out. I have a question about a similar question. Who would you recommend calling first with a medication side effect? Would you call a pharmacist, or would you call the prescribing pulmonologist? Would you call the nurse specialist? And I do also, with a caveat, I think that oftentimes you're calling one number and then saying what you're talking to a triage person, they'll send you where to go. But if you have different numbers for your organization, who would you recommend to call first?
I would say if it's between calling, let's say you're worried about a medication side effect, it's between the specialty pharmacy where you obtain them, that sends out the medication, or your physician's. I would call the physician's office, and oftentimes speaking with the nurse. Again, we sometimes hear back from patients thinking it's a side effect of a medication, something else is going on, and we want to sort that out. So I would say that one I would go to, if it's about a medication side effect, I would say it should be to the physician's office, and as Dr. Case mentioned, it's likely going to be a triage, which is often the nurse that's answering those calls. And I know not every clinic offers a devoted nursing line. A lot more are now doing that, but that would be a good one for nursing line. But even if you went through the more the administrative staff, they would say, oh, you have a medical issue. Okay, let me get you to one of the nurses, more than likely.
So I have a couple of questions about the different members of the team. I'll just start with with the first one. This is about a social worker, accessible at all of our CCN sites. They're not necessarily always a member of the core team as they are at your organization. So there are a lot of people who are probably not familiar with the role they might play and how they could be helpful. It was really nice to hear some of those roles. A question here about whether a social worker could be able to assist with transportation assistance in getting back and forth to appointments, because that can be a barrier for some of our patients.
Yeah, I think that's another good question. I think I can tell you what we've encountered, and before we had a social worker with our team, we would sometimes even have the patients contact directly the insurance company, because some of them do support that. The other thing that a lot of insurance companies are starting to have is sort of a care advocate. It's almost like a case manager within the insurance company for anyone with any chronic medical issues who may need more support if that's not readily available. The other resources that we used was when a patient was within the same healthcare system. We would rely on the primary care sort of case management. Sometimes it's a nurse or a social worker, but case management in general is often available in areas, and that's another place to kind of potentially have support. But I think it's really through asking the physician's office, oh, is there somebody that helps with if I can look into transportation, or even with within the primary care's office as well.
Great. So next question is about working with a respiratory therapist. I know these are folks who are really important in our pulmonology offices. Our patients get to know them during their pulmonary function testing, and then, those who are prescribed oxygen, they certainly have a little closer relationship because of that, that need. The question here is working with a respiratory therapist always recommended for a pulmonary fibrosis patient? And if my care team hasn't brought it up, can I request it?
Good question. So some of that is just how the clinic is structured. We work really closely with, and just to give an example of what I know is, we work closely with our respiratory therapist, but does every single patient meet one? No, I think it probably, as you said, probably goes along with when somebody's needing oxygen, they might need that respiratory therapist. They may also spend more time with one of our pulmonary nurses as well, and so there can be overlap there. So if there's not a respiratory therapist immediately available to you, it doesn't mean that you're not getting good care. There's likely a nurse that's been filling that role, and as Dr. Case had mentioned, there's tons of overlap there. I think the places that the other places besides clinic that there would be access to the respiratory therapist would be in pulmonary rehab. And I'm not sure that people are always aware that they're working with the respiratory therapist when they're at pulmonary rehab, or that that there is someone there specifically with that role, but oftentimes there is. But if that's not part of the care team, you can ask, oh, is there a respiratory therapist? But I don't know that I would say that, that it means that you should leave that practice, or that there's someone likely filling in that role of what the respiratory therapist, that education component. And like I said, a lot of overlap for respiratory therapy and pulmonary nursing in that respect.
That's perfect. Yeah, so it's almost like a care team has a set of responsibilities, and how they share those responsibilities among the different healthcare professionals may look a little bit different. There may be some, the team may be bigger, it may be smaller, it may be, the responsibilities may fall differently, but they are all kind of covering the same set of responsibilities. And it may be that for one patient, that respiratory therapist, they're not on oxygen, they don't necessarily have a need for pulmonary rehab right now, things like that. They may not be playing a direct role in their care aside from pulmonary function testing, things like that directly in the office, but they may be able to step into that role should that need arise in the future or something like that. So they're there and accessible and ready if their skills are needed in that case. So you brought up the role of a respiratory therapist in pulmonary rehab, and certainly our pulmonary rehabilitation professionals are oftentimes respiratory therapists, but there are programs that are great programs that are run by physical therapists around the country, and there are different splits in different places, and each individual institution might take that differently. Is it better for our pulmonary fibrosis patients to be in a program with a respiratory therapist versus a physical therapist?
That's a good question. I think certainly being in the program at all, to me, is the biggest deal there. That getting you to a place where you can start working on improving some of your exercise tolerance and breathing techniques to help with symptom control, I think is the most important thing. So as Dr. Case described well, it's more that there's a set of responsibilities and making sure those responsibilities are addressed. Making sure those are addressed. So I wouldn't say that if the program again just has a physical therapist, that physical therapist is likely filling the role of what a respiratory therapist might do in another program, whereas another program might have a respiratory therapist but no physical therapist. And so again, there may be some again, just shared responsibilities there.
I think that's another, just a really good example of the, again, set of responsibilities, and many, the AACVPR, so Cardiopulmonary Rehab Association, they have a set of standards and program, goals that need to be met and things like that that go along with their accredited programs. They don't necessarily have to be carried out by one healthcare professional or another, as long as the needs of the patient are being met within that program. And so, it may not be that you need a respiratory therapist or a physical therapist, but a program that has a set of standards. And it's always good to ask, what is this going to look like for me? Are there those educational components as well as the exercise components? Are there monitoring components? Do you communicate back to my doctor? Things like that would go along with a program that's going to meet the needs of a PF patient really well. We have a question about pulmonary rehab being something that is not always easily accessible for payer reasons or for distance reasons, and do we have any suggestions on maintaining that, or going back after a period of time? I'm going to use this moment, if you don't mind, Krishna, just to say that if you haven't, for those of you out there who haven't discovered, on the Pulmonary Fibrosis Foundation's website, we have a pulmonary rehabilitation toolkit there. And clinically, I have used this to suggest to people, if they're distant, if they're worried about, right now in the pandemic, COVID exposures, if their program is closed, if they're, between sessions or something like that, and for many reasons that access is limited, they can utilize those exercises. There are videos and educational resources within that package. It's there. It's completely free. It's, anybody can access just on their computer. And it's geared for people to be able to do in their home environment without any super special equipment. I think the other piece of pulmonary rehab about, maintaining that is, hopefully there's been an educational component, and the things that you've been able to learn and take away from that can be continued once the initial, period of pulmonary rehab is completed. That some people like to transition to a home environment, or to, in better times, the Silver Sneakers program or something like that, where they can continue to progress and improve upon the gains that they had made and maintain those. Thank you, everyone. Again, Dr. Devaraja, thank you so much for joining us. This has been a really wonderful and educational session. I've loved talking with you about care teams and how we all work together, and I hope everybody's learned a little something today. So have a great rest of your afternoon, and we will see you in the new year. Bye.
Thanks, everyone.